Hi, Mrs. J. This is
Hi.
Miss Josie. How are you? How are you, coders? Welcome to Tuesday night group study, and we're going to go over the steps to solve a CPC exam. Please welcome Mr. Sandeep. Come on out and say hello, Mr. Sandeep.
Hello, good evening, coders. Good evening, Miss J. Good evening, Miss Josie, Miss Courtney, Miss Dolly, Miss Carla, Miss Vivian, and Miss Eva. I think I named them all. I didn't miss anyone. So welcome back to the second session of group study classes. All I have to say is buckle up, coders. Today we are having some good scenarios for you, and I'll be coming back to take some of them. So see you in the chats.
Thank you, Mr. Sandeep. And Miss Eva.
Hi, coders. Good evening. How are you guys? How was your week? I hope you're doing awesome and hope you're excited as I am to do some honest. What is it? Just coding. Just code, coders. You're doing great.
Thank you, Miss Eva. And I'm Miss Josie, your co-lead. And I'm excited that you're here because we're going to learn a lot about breaking down these case scenarios for the respiratory system and cardio. This is exciting. Are you ready? I'm going to bring out Mrs. J.
Hey, hi everyone. It is so good to see everyone. We have a fantastic group tonight. There's a lot of you here tonight, so I'm excited. It is a beautiful evening where I am. I'm in Pittsburgh, Pennsylvania. Where are you? Go ahead, type in the chat. Let me know that you can hear me. How does my sound? How is my sound? How is my sound? Does
You
my
sound
mic?
good, Mrs. J.
Okay, I wanted to sing. Awesome. Thank you so much. Does my mic sound nice? Good. All right, take it away, Miss Josie, and introduce our amazing interns.
All right. I'm excited to announce these fabulous interns that are working hard behind the scenes. Miss Carla, coming out and say hello.
Hello, team. Hello, Mrs. J. Hello, Miss Eva. Hello, Miss Vivian and Mr. Sandeep and the rest of the A team. Welcome, coders. I'm glad you're here. Hope you all are having a great week so far. So let's get it. Let's code, coders.
All right, Miss Carla. Thank you for being here tonight. Miss Courtney, come on out and say hello.
Good evening, coders. We're excited for you to be here with another awesome group study. We've got a lot of great scenarios, so let's get to coding.
We're off to a great start with Miss Courtney. Miss Vivian.
Good evening, coders. I hope you have an awesome study group today. I think we'll learn a lot today with our awesome instructors. So let's have fun.
Thank you for being here, Miss Vivian. And Miss Dolly, come out and say hello to the coders.
Hi team, hi coders. I'm excited to dig into some scenarios with you guys and I'll see you in the chat.
Yes, I think it'll be a lot of fun. Miss Anu, come on and say hello.
Hi everyone. Good evening all. I'm very glad to be here. Let's see you all in the chat.
Yes, we're all ready to get started. We're going to turn it over to Mrs. J.
All righty, thank you so much. And welcome, welcome, welcome. We have we have some amazing interns, some great voices. I love it. I love it. I love it. All right, goals of the presentation tonight. We're going to review one respiratory scenario. We didn't get a chance to get to it last week. We're going to get it done tonight. Cardiovascular scenarios, digestive system, urinary mail system scenarios. And before we get started, let's review how to solve a multiple choice case study scenario for the board exam. Typically, these will be operative reports. First things that you need to do, highlight your key terms. Remember our key, yellow for diagnoses, green for procedures, and pink if it's inclusive or bundled. Number 2, document your inventory, your procedures, diagnoses, and select the primary. Number 3, review guidelines. And 4, select the code that best matches your inventory list. All right. Since we've been doing this, we've been noticing that when you're highlighting, there are some things that you don't have to highlight. You just don't, because you're never going to code them. Number 1, things observed by the physician. Number 2, closures such as sutures and staples, etc., for non-integumentary. I have to stipulate that, because if it's an integumentary procedure, you're often going to have to code the sutures or the closures. However, who has a huge operative report for integumentary? I'm talking about like repairs, honestly, and lesions. All right, number 3, hemostasis, such as bleed control, drains, irrigation of the surgical site, installation and removal of clamps and or trocars, dressings, surgical risks. So you're not going to code those. Now, let's get started. Let's go ahead and review our respiratory system scenario. All right, Mr. Sandeep.
Thank you, Mrs. J. So coders, we will kick off with a respiratory system scenario. We have just got one, and let's do it. Ms. Courtney, I would like to invite you to read out this first scenario for us.
All right, so I'll read the question first for everyone. What CPT and ICD-10 CM codes are reported? A, 32669 and C34.11, B, 32662, C34.11, C, 32663 and C34.11, D, 32666 and C34.11. Preoperative diagnosis, mass, right upper lobe. Postoperative diagnosis, carcinoma, right upper lobe. Procedure performed, VATS, right superior lobectomy. Description of procedure. Under general anesthesia, after a double lumen tube intubation, the right lung was collapsed and the right side up is oriented so the patient is in the left lateral decubitus position. We prepped and draped the patient in the usual manner and gave antibiotics. Then 2 1-centimeter incisions were made along the posterior and mid-axillary line at the 9th and 7th intercostal spaces. The lung was deflated and a camera was inserted. A longer 6-centimeter incision was made along the 4th intercostal space anteriorly. We then freed up some adhesions at the top of the lung, both in the superior area away from the tumor and in the anterior mediastinal area. The tumor seemed to be in the right upper lobe. The dissection began by ligating the superior pulmonary vein and its branches, and the upper lobe was freed up. The small fissure was incomplete, and I proceeded with the lobectomy. The pulmonary artery branches were then ligated. The bronchus was ligated as well. The superior branches to the upper lobe were ligated with endo-GIA. The lobe was freed up and sent to pathology. The wound was then closed in layers. A chest tube was placed to suction, and the patient was sent to recovery in stable condition. Pathology confirmed carcinoma. All right, coders, your time starts now. Put your answer in the chat.
Thank you, Miss Courtney, for reading out that scenario for me. So coders, that's your 2.5 minutes. And what a fantastic way to start this study session. I can see your answers in the chats. Awesome job, coders. Now let's move on and look into let's move on and solve this scenario. Now you can see and highlight first step comes is highlighting the keywords, and now you can see in the post-operative diagnosis it's a carcinoma of right upper lobe, while in the pre-operative diagnosis it was a mass of right upper lobe. So in surgical scenarios always pick up the post-operative diagnosis because that is one which doctor confirmed or the surgeon confirmed after the procedure. And now in the procedure, we have got VATS, right superior lobectomy, which is video assisted thoracoscopic surgeries. And general anesthesia was given. Then two 1 centimeter incisions were made on the posterior and mid axillary line at the 9th and the 7th intercostal spaces, and the lung was deflated and a camera was inserted. Now you can see that's a thoracoscopic video assisted thoracoscopic surgery. Now, later, the tumor seemed to be in the right upper lobe, and the superior branches of the upper lobe were ligated with endo-GIA. And finally, the pathology confirmed the carcinoma. Now, let's move into the second step, that is getting our procedure inventory and the diagnosis inventory. So as I said, in the procedure inventory, we are having VATS, right superior lobectomy, and the diagnosis inventory, we are having carcinoma of right upper lobe. And these are our code options. And now you can see the anatomy of lungs. In the right lung, we have got 3 lobes, and the left lung, we have got just 2 lobes. And in the right lung, you can see where's the tumor located. It is in the right upper lobe. And the right superior lobectomy is a procedure which is performed. Now you can see an image over here. This is what VATS surgery will look like, where doctors will be making incisions through which the scissors and the camera is inserted. And you can also see another device which is used for the ligation and cutting. So this is the procedure which is almost performed in our scenario. Okay, in the procedure inventory, it is very important to look into the this portion, that is right superior lobectomy, because that is going to drive us through to the final answer. It is right superior lobectomy that is performed in our scenario. Let's look into option D first. It is coding for 32666, and let's look what it is, what the code language is. It is thoracoscopy with therapeutic wedge resection, initial unilateral. Once again, cross-checking with the procedure inventory, it is not a therapeutic wedge resection which is performed. Actually, in a therapeutic wedge resection, removal of a small wedge-shaped piece of the lung tissue will be happening. It might be a tumor, so it will be removed in a wedge shape. Well, you can see it's a lobectomy that was performed in our scenario, so we can eliminate option D, 32666. Now let's look into the option A, that is 326691. It is coding for a thoracoscopy with removal of single lung segment, that is also known as segmentectomy. Again, it is not a segment removal which was performed. It is much bigger than a segment. So therapeutic wedge resection is smaller, and something which is bigger is a segmentectomy, and something which is bigger than a segmentectomy is a lobectomy. So we can eliminate option A as well. Now remaining 2 options are option B and option C. Let's see what's 32662 is coding for. It is coding for thoracoscopy with excision of a mediastinal cyst, tumor or mass. And once again, it is not a mediastinal cyst or tumor or mass which is removed. That brings to the last option which we are having. It is or the correct answer will be option C, 32663, C 34.11, and that will be coding for thoracoscopy with lobectomy single lobe. And that's why I said always have the procedure inventory and cross-check your answers with the procedure inventory, because in the procedure inventory we had a VATS, right superior lobectomy. So it is a lobectomy which is performed. What doctor did is a removal of the right upper lobe, along with the tumor. So that's the correct answer. So always coders select the code that best matches your inventory. If you have any doubts in this scenario, please put your questions in the chats. We will be happy to assist you. So that's the only scenario which we are having in the respiratory. Back to Mrs. J. The floor is all yours.
Oh, wow. What a great explanation. And coders, you rocked. A lot of you got that correct. And if you didn't, I saw an aha moment. So again, if you have questions, go ahead, place your answers in the chat. Now we're going to move on to cardiovascular system. All right, so I'm going to ask Miss Eva, will you please do me the honor?
Sure thing, Miss J. Ready, coders? Here we go. Preoperative, I'm sorry, let me read the question first. What CPT and ICD-10 CM codes are reported? A, 33720 Q2549. B, 33702 Q2549. C, 33710 Q25.49. D, 33710 37187 Q25.49. Preoperative diagnosis: sinus of Valsalva aneurysm on the left coronary sinus. Postoperative diagnosis: same. Operation: repair sinus of Valsalva aneurysm with pericardial patch. Procedure: the patient was taken to the operating room and placed supine on the table. After general endotracheal anesthesia was induced, rectal temperature probe, a Foley catheter, and TEE probe were placed. The extremities were padded in the appropriate fashion. Her neck, chest, abdomen, and legs were prepared and draped in standard surgical fashion. The chest was opened through a standard medium sternotomy. The patient was fully hyperonized and placed on cardiopulmonary bypass. At this point, we started to open the pericardium. We were met with a large amount of dense adhesions and some fluid that was blood tinged, salmon color, and okay, Miss J, thank you. Um, Okay, let me go a little bit back. At this point, we started to open the pericardium. We were met with a large amount of dense adhesions and some fluid that was blood tinged, salmon color, and it was cultured. Tonsil clamps were placed on the inferior portion of the pericardial sac, and we used Bobby cautery and Metsamboune scissors to take down all the adhesions laterally, exposing the right atrium first and then the aorta. There were some lighter adhesions over the left ventricle, which were broken with finger dissection. There was a moderate amount of fluid in different pockets that were suction free. There was no evidence of frank blood. After dissecting out the right atrium, we dissected out the aorta circumferentially using Bobby cautery and Metzabom scissors. We then free up the entire LB and the apex, as well as the interior and lateral borders of the heart. After this, we then checked the activated clotting time, ACT, which was greater than 550. The ascending aorta was cannulated without difficulty. A dual-stage venous cannula was placed in the right atrium. Retrograde cardioplegia was placed in the right atrium through the coronary sinus, and antegrade cardioplegia was placed in the ascending aorta. After the patient was on bypass, we completed dissection. We looked through the superior pulmonary vein, and it appeared to be densely adhesed, so we opted to bend through the apex end of the LV. We proceeded to flush our lines, cooled to 32 degrees. Once we had a nice arrest, we opened the aorta. An aortotomy was created in standard fashion. The area was stacked back, and we were able to identify the aneurysm in question. There was a large amount of thrombus, and it was created in and it was removed, I'm sorry. There was also some mural thrombus, which was laminar and stuck to the aneurysm, and I elected not to debrief this area. This defect apparently took up the entire left of the sinus of Valsalva. The coronary was probed and there was approximately a 2 to 3 millimeter rim of tissue beneath the coronary to suture, and the bulb was intact. The aortic valve was intact and there was a rim of tissue just lateral to the annulus for us to suture. After debriefing and irrigating, we seized a bovine pericardial patch and sutured it in place with a 4-0 Prolene suture. This was done in a running fashion, working from the annulus up towards the coronary artery underneath the coronary, and then around laterally and superiorly sewing through the aortic tissue. We now successfully excluded the aneurysm and packed the entire sinus. We gave cardioplegia in a retrograde fashion with nice flow back from the left main. We inspected the repair and it was competent. We irrigated one more time and closed the aorta, de-aired the heart and with standard maneuvers and removed the cross clamp. We then weaned the patient off of bypass and rewarmed the patient. There was no aortic insufficiency, good function of the aortic valve, and no flow into the aneurysm anymore, with a nice patch repair. We closed the chest with stainless steel wires. The fascia was closed with vicryl sutures, and subcutaneous tissue and skin were closed in similar fashion. What CPT and ICD-10-CM codes are reported? Coders, you have 2.5 minutes.
Wow. You know what? My chat was not working, so I didn't think anyone had responded, and you all are rocking. And I know I'm a little early. Who needs more time? Say, give me some more time, Mrs. J. Look at that. All right, I'm going to get started. Overwhelmingly, you all gave the correct answer. And somebody said, wow, that was a long scenario. Well, our objective today is to kind of give you some level of, I don't want you to have anxiety when you see these. I want you to have confidence when you see these long scenarios because I want you to make this your strength. I want you to be confident, and this is how you're going to do it through practice. Okay, Sinus of Valsalva aneurysm on the left coronary sinus. That's the preoperative diagnosis. The post is the same. Your repair, sinus of Valsalva aneurysm with pericardial patch, that is your procedure. Supine on the table, endotracheal anesthesia, Foley catheter and TEE probe were placed, median sternotomy, cardiopulmonary bypass, opened the pericardium. There were dense adhesions, Bovie cautery, Metzenbaum scissors, take down all adhesions laterally, adhesions over the left ventricle, broken with finger dissection, fluid, suction free, dissecting right atrium, dissected. And you don't really have to, if it's the same, you don't have to highlight it, but I'm just doing it. Aorta circumferentially freed up, ascending aorta cannulated without difficulty. Venous cannula was placed. Retrograde cardioplegia, antegrade cardioplegia, bypass, dissection, adhesed, vent through flushar lines, cooled to 32 degrees, and aortotomy, tacked back, aneurysm, thrombus, removed, thrombus, laminar and stuck to the aneurysm, probed, debriding, bovine pericardial patch, sutured it, closed the aorta, de-aired the heart, weaned patient off bypass, rewarmed the patient, and the answer, as you all have said, is A. How did we get to this? Well, before we do that, I want to show you a little bit, give you a little bit of the anatomy of the, first we'll start with the aorta. Now we know the aorta, if you didn't know, you're going to know now, right in this section, this is your heart, and the aorta begins at the left ventricle, and then it extends upward into the chest to form an arch. And then it's going down the abdomen. You see, this is the diaphragm. You see your renal arteries, and then it splits into the iliac arteries. There you go. So the aorta goes all the way down your trunk to the iliac. And this right here is your sinuses of Valsalva. So we had an aneurysm right here. Now, if we look at an actual one, your aortic valve is here. The sinus of Valsalva, this is actually an aneurysm. So there you go. And this right here, that's your pericardial patch. Yeah, so that's what they use to repair the aneurysm. Now, let's go ahead and solve this scenario. Our, what our instructions are here at the top, and let's go ahead. We've already highlighted our key terms. Now we're going to go to 2, and we're going to document or inventory our procedures and diagnosis, and then we're going to determine which is primary. So our inventory of procedures, we only have one, and if we look at the other 2 green, they kind of are integral to our repair sinus of Valsalva aneurysm with pericardial patch. All right, so that is our procedure. Also, we are aware that cardiopulmonary bypass did take place, and that's it. Now we do have inventory of our diagnoses, and it's just one, sinus of Valsalva aneurysm of the left coronary sinus. Just one. And our codes are in close proximity. So this will require that we be very forensic. And if you look at 33702, this is the code for repair sinus of Valsalva fistula. We don't have a fistula. No, we have an aneurysm. So any code related to the 33702 family is incorrect, right? So we're going to eliminate 33702 and 33710 because remember, all of the common portion language, if it's shared in the family, and if the common portion language is incorrect, that entire family is incorrect. So we're going to eliminate 3302 and 33710, right? Boom, boom, boom. And your answer, 33720, repair of Valsalva aneurysm with cardiopulmonary bypass. The bypass is included in the code language. So A is correct, and that is the code that best matches our inventory list. This code language best matches the inventory list. All right, so you all nailed that. Now, if you have questions, go ahead, type it in the chat. And now we're going to move on, and I'm going to ask Miss Anu to read the next case.
Hello, coders. Ready for the next scenario? Okay. What CPT and ICD-10-CM codes are reported? A 36556 N 17.9, B 36558 N 18.9, C 36561 N 18.9, and the D is 36563 N 18.9. Preoperative diagnosis: acute renal failure. The post-operative diagnosis same as acute renal failure. Indication: patient is a 23-year-old critically ill woman who went to the operating room for a lung transplant. A vascular path was indicated to proceed with CVVHD upon arrival in the ICU. Procedure: left subclavian vascular catheter placement insertion. The left chest was draped and prepped in the usual sterile fashion, and the patient was placed in the Trendelenburg position. The subclavian vein was readily located with a needle, and the Seldinger technique was used to place a vascular catheter for dilation. Excellent flow was returned through both lamens. The catheter was secured in place and a sterile dressing was applied. The patient is to be transported to the ICU where a post-procedural X-ray will be taken. What CPD and ICD-10-CM codes are reported? And your time starts now.
All righty, you all are rocking it. And for the first time, I think I'm going to help somebody. Okay, let's get started with those keywords. Before I do that, I want to thank you, Miss Anu, for the wonderful read, and you too, Miss Eva. Okay, our preoperative diagnosis is acute renal failure. The post is the same. All right, this woman is going for a lung transplant. You see, it's pink. It's pink because we're not going to code for it. All right. A VAS cath was indicated to proceed with the CVVH. That's continuous venovenous dialysis. ICU. Now the procedure: left subclavian VAS cath placement insertion, left chest, Trendelenburg subclavian vein, Seldinger technique, VAS cath for dialysis, and the answer is A. Yes, it's A. Now let's go ahead and finish up. We need to document or inventory our procedures and diagnoses and then select the primary. So those inventory of the procedures, and remember, we start with the procedures first because in CPT or for the CPC exam, that is how it's documented. Yeah. All right. So left subclavian VAS cath placement insertion is our procedure. The diagnosis is acute renal failure, right? Oh, 1 second. All right, there you go. So you can select the code that best matches your inventory list. And let's go ahead and let's look at our guidance. This is the MCG manual. There are guidelines on coding central venous access procedures, and the guidance is here. So let's go ahead and take a look at it closely and determine how to code out this scenario. All right, so here are our procedures and diagnoses, and this is the guidance. We'll need to answer these questions. And these answering of these questions will help you know which code you should select. All right. Also, you need to know this, that insertion of a non-tunneled, centrally inserted central venous catheter means, when it's non-tunneled, it means that it was superficially inserted, meaning it went through the vein. They didn't have to burrow through or go deep, just to let you know that. Then again, I am getting out of order here, but I want to show you. Let's go ahead and answer these questions. Is it catheter or device? It is a catheter because the documentation says it was a catheter. It said a catheter was, a VAS catheter was placed, right? Cath was indicated to proceed, right? The age of the patient. All right, so age isn't too pertinent as long as this patient is older than the age of 5. So we got that. Now we need to know, is it centrally or peripheral access? We know it's central because it says that this is the left subclavian vein. All right. Okay, Mrs. J, you lost me right there. Right. So this requires that you know a little bit about the anatomy. It's centrally placed when, and the guidance is right here, it says the catheter tip must reside in the subclavian, the innominate or iliac veins, the inferior or superior vena cava, or right atrium to be considered a central venous catheter, right? So the subclavian tells us that this is centrally, it's a centrally located, all right? Also, selective or non-selective isn't pertinent. Where will the catheter reside? The subclavian, we have that. Is it tunneled or non-tunneled? All right, now I started telling you about tunnel and non-tunnel, but it is non-tunnel because it's superficial. It's in the vein. Now think about tunnel. When you have to tunnel something, you have to burrow deeper. All right. So if you have to burrow deeper, it is tunneled. Usually they use some sort of guidance like fluoroscopy, but if they're just going right in the vein and they can fish it on through without any assistance, 9 times out of 10, it's superficial. Therefore, it is non-tunneled. All right. Is there a port or a pump? There's no mention of a port or a pump. Midlines or PICs, we don't have, that's not pertinent. Image guidance, and it says PC parenthetical guidelines. We don't have any imaging guidance. All right. So I think we're ready to roll and go ahead and code this out. So I decided, let me show you how I chunned my codes. All right. So up at the top, just so you know, the subclavian vein says that this is centrally located. It is a Voss catheter. Voss means vein. They went through the vein, so it's non-tunneled as well. All right. So let's go ahead and circle our families. And if you want to go ahead and screenshot, you can. Okay, so I'm going to go ahead and chun my families. So the first family, 36555 family, and it includes 36556, which is A. This is insertion of a non-tunneled centrally located catheter. Okay. The family 36560, this is the family for insertion of a tunneled centrally located catheter. Below it, insertion of a tunneled centrally located catheter with a pump. Beneath that, insertion of a tunneled centrally located with separate access points without a pump or port. And then over to your left, 36557 family, insertion of a tunneled centrally located catheter without a port or pump. So if I say it like that, we are looking for a centrally located, non-tunneled catheter placement. There's only one here, this family. Because this family, 36557, is tunneled. 36560, tunneled. 36563, tunneled. And 36565, that's tunneled too. So we're going to get rid of 36558, 36561, 36563, and our answer is A. Or you just could have looked at the ICD-10 CM code N17.9. That's acute renal failure, as opposed to N18.9, which is chronic CKD. Remember, our patient had acute renal failure. All right. So one more thing. Don't forget this central venous access procedures table. All you have to do is look for your circumstance. Remember, we had a centrally located, non-tunneled situation. Okay, so it's only here. This could be our option here. Here or here. That's it. We can select our codes from here or here. That's it. But our code, I believe, came from here. So don't forget your central venous access procedures table in your CPT manual. All right, so go ahead, talk to me in the chat, and I'm going to hand it over to Ms. Josie. All right, Ms. Josie, take it away.
Thank you, Mrs. J. Okay, coders, I'll begin with the what CPT and ICD-10 CM codes are reported. The answers are A, 33877, 33858, I-71.2, and I-71.01, B 33859, I-71.2, I-71.01, C 33875, I-71.2, I-71.01, and D 33863, I-71.1, I-71.01. Preoperative diagnosis, 6.7 centimeter descending thoracic aortic aneurysm, type B, dissection, chronic. Postoperative diagnosis, the same. Operation, left thoracotomy, repair of a descending thoracic aortic aneurysm with a 34 millimeter gel weave graft. Bypass time, 1 hour, 15 minutes. Procedure. The patient was brought into the operating room and placed on the table in the supine position. A blocker was placed on the left main stem bronchus, and we isolated the left lung. We proceeded to place the patient in the right lateral decubitus position. He was padded and secured with all pressure points relieved, and at this point we prepared and draped the patient in the usual sterile fashion. We performed a left posterolateral thoracotomy, dividing all the muscles. The fourth intercostal space was entered. The lung was completely deflated. At the same time, we exposed the left common femoral vein as well as the left common femoral artery and heparinized the patient. These vessels were isolated and prepared for cannulation. A venous line was placed into the right atrium through the common femoral vein, and this was secured. The patient was placed on partial bypass, maintaining a blood pressure in the lower extremities of around 50 mmHg. We continued at this point with our dissection. The esophagus was plastered against the aorta. It was peeled off. Intercostals were controlled and divided. We placed an aortic cross clamp proximally and distally, and we entered the aneurysm. We identified 2 lumens, and these were resected, and proximally we identified the true lumen and resected the false lumen after obtaining control of the subclavian artery. Distally, we fenestrated the wall between the true and false lumen to prevent any malperfusion. At this point, we sized the aorta to 34 millimeter aortic graft, and we fashioned the proximal anastomosis using a 3.0 Prolene with a large needle in a running fashion. After examining at this point, we removed the cross clamp and pressurized the anastomosis. Areas of the leak were controlled with a 4.0 Prolene. The graft was cut to length, and after examining our distal aorta and making sure an appropriate fenestration had been performed, we fashioned an anastomosis again using 3.0 Prolene with a large needle. Before removing the proximal cross clamp, we de-aired the graft with a 25 gauge needle. We very slowly removed the proximal cross clamp as well as the distal cross clamp, and flow was reinstituted down the aorta. We weaned the patient off bypass and examined our distal and proximal anastomosis. All incisions were closed and the patient tolerated the procedure well. Coders, we'll give you another minute and a half on this because most of you have your answers. You may begin. All right, coders, very impressive. You guys rocked the chat. You guys did very good. Almost 100%, Mrs. J.
Yeah, so you all, thank you so much, Miss Josie. So you all don't really need my instruction. Okay, but we'll quickly go through this. Our preoperative diagnosis is 6.7 centimeters descending thoracic aortic aneurysm, type B aortic dissection, chronic. The postoperative diagnosis is the same. The operation, left thoracotomy, and repair of the descending thoracic aortic aneurysm with a 34 millimeter gel weave graft. All right. So my keywords: supine position, right lateral decubitus position, padded and secured, prepared and drape, posterolateral thoracotomy, dividing the muscles, lung, deflated, exposed the left common femoral vein, left common femoral artery, so if you want to say it either or, heparinized, isolated, prepared for cannulation, venous line, secured, partial bypass, dissection, esophagus, plastered, aorta divided, entered the aneurysm, resected, resected the false lumen, control of the subclavian artery, fenestrated, size the aorta to 35 millimeter aortic graft, fashioned the proximal anastomosis using 3-0 proline, nerve hooked this suture line and tied this down. Posterior suture line of proximal anastomosis was reinforced. 4-0 proline pledged stitches, removed the cross clamp, pressurized the anastomosis. Leak were controlled with 4-0 proline. Graft was cut to length. Appropriate fenestration, fashioned an anastomosis. Large needle, de-aired the graft. We weaned the patient off bypass. And the answer, C. And a lot of you said that. All right, so in the last time that we spoken, or the time before that, we saw the aorta. So I just want to let you know that the descending aorta is what we are focusing on. The aneurysm occurred right in this section. I wish I had a darker color. Now let's take a look at these aneurysms. All right, so you have your type 1, type 2, type 3, type 4. More than likely, our aneurysm was something like this. And even though this type 2 may be above the diaphragm and below, up in this section where the descending thoracic aorta is, there was mention of a dissection, right? So that's pretty serious, okay? So an aortic dissection is when a tear occurs, like right here, in the inner layer of the body's main artery, and then blood rushes through that tear, causing the inner and middle layers of the aorta to split or dissect. Now, type B refers to the descending aorta. So there you go. We have a type 2 and type B. No, I don't know if we had a type 2. I'm pretty sure it's either type 1 or type 2. Let's go with type 1 because this is where the aneurysm was, okay? The documentation didn't state, but I'm just deducing that it is type 1. Now, they repaired it. How did they repair it? They repaired it with the gel weave, right? So this is what it looks like on the left, and on the right, this is how it was applied. Looks like a little bandage for the aortic arch. Now let's go ahead and solve. We've highlighted our key terms. Let's go ahead and inventory our procedures. A left thoracotomy. You know what? That's the approach. That's how they approached it, right? Repair of a descending thoracic aortic aneurysm and a partial bypass machine. Our diagnoses: 6.7 cm descending thoracic aortic aneurysm, and it was a type B aortic dissection and chronic. Our job: select the code that best matches the inventory. All right, so let's go ahead and look at our families. If we look at the 33858, you'll see that that is A and B family. All right, so 33858, this is the code for the ascending aorta, right? So ascending aorta is the common portion language, ascending aorta graft with cardiopulmonary bypass. Okay, so we're going to stop here because we need a code that codes for the descending thoracic aorta. So 33858 is incorrect, as well as 33859 is also incorrect because it's the common portion language for both codes. And if the common portion language is incorrect, the entire family is too. So that eliminates A and B. Now, if we look at 33863, that's D, ascending aortic graft with cardiopulmonary bypass. Same thing, it's incorrect as well. So our answer will be found down here, 33875. This is the code for descending thoracic aorta graft with or without bypass. And they're talking about the cardiopulmonary bypass. And we're coding for the descending aortic, thoracic aortic. 33877 is also incorrect because it's coding for the thoraco-abdominal aortic aneurysm, and that did not happen. There's no mention of that. So C is our answer. A, B, and D are all incorrect. All right, coders, talk to me in the chat.